Sir, we are live now.
Yeah.
So good evening, doctors and all the participants. Shuman on behalf of Shield Healthcare, welcoming you all today with another very interesting and emerging topic, that is UTI in women's health. And our guest speaker is Dr. Samir Hajra sir again. So it's my honor to introduce sir, although everybody knows sir very well, and just it's my formal responsibility to introduce sir. Sir is the senior consultant obstetrician and gynecologist, Hospital for Women, R.C. Hajra Memorial Hospital in Dhanbad. And in terms of awards, I'm not going to detail of any awards, sir. Throughout her lifetime, achieved many things. Just to highlight few things, sir. Received National Award for Best Hospital Administrator from Six Sigma Military Academy by Health Minister and Defense Ministry at New Delhi. In terms of training, sir did many trainings. Means almost all the trainings I already did. And apart from that, attended conference. In many conferences, sir attended as a guest lecturer, as a guest speaker, invited speaker as well, and attended many workshops and many papers presented in many national and international seminars. So with this short introduction, I request sir to take over the session. And meanwhile, I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with sir. And thank you very much, sir, once again for your valuable time to share your knowledge with this medical fraternity in our Shield Connect platform. So thank you very much, sir, and over to you, sir, for further proceedings. Thank you very much.
Thank you. I'll just load the screen.
Yes.
Am I visible now? Is the screen?
Yes, sir, everything is perfect. Everything is perfect, sir. You can.
Well, at the outset, I like to thank Shield as such, because it is the Shield's and its like energy and its support to our womanhood or our motherhood or our female dear most coveted respectable patients. It is Shield who takes the initiative to do all these strong things. Today, I like to thank Biplav along with his full team, with Sumanda as well as other dignitaries who are there, and a special thanks to the whole team working together as a full year. I am Dr. Samir Hajra. As you all know, I'm CEO cum medical administrator of Hospital for Women, and the special obstetric wing is called R.C. Hajra Memorial Hospital. It is in the name of my great grandfather. Again, coming back to the topic, I have been trained in gynae macrovascular surgeries, oncology surgeries, breast cancer surgeries, as well as high-risk obstetrics, as well as general gynecological surgery, infertility, as well as assisted reproductive therapy with IVF, as well as laparoscopy and hysteroscopy. Many things that I don't want to go in detail, but only thing I want you to know that, see, so many things we need to do just to make one patient happy. My main intention is that just to make them super happy. I did medical administration and MBA from John Hopkins Boston University as well as Harvard. Then I did my hospital administration. I got a trained in Black Belt, Six Sigma, Lean practicing. All these things. Why I want to just show, it's not just to show my caliber, nothing like that. It's only just to show you, just if you want to care and love your patient, these are the things which makes you more perfect and more like vulnerable to their needs. And when you are perfect in their needs, like how Shield is supporting us, being in a team, we feel proud that we are saving the mankind. Now today's topic is a very burning topic, and it leads to burning urine also. So I am very happy to lead this group, because urine as such is one of the most basic thing which excretes our body functioning or excretion system, so that our body works perfectly. So this UTI has got a great role, and whenever our urinary tract infection happens, our whole system collapses. Our main cheese what? Kidney, bladder.
Sir, sorry for the interruption, sir. Slide is not moving, sir. Maybe some reason. So can you please unshare and share?
In my screen that is moving.
But here, sir, it is not moving.
It is fixed now, na?
Yes, sir.
How to do it?
Sir, can you please unshare and share your screen share?
Sure, sure. That is what I'm trying to. Is it coming now?
Yes, sir, it is coming now. Sir, can you please change? Yes, it is coming now. Fine, sir. Thank you.
Fine. See, women are always at greater risk of developing UTI than men, because most and the foremost thing, we need to understand the anatomy. The urethra, which connects the vagina or the vulva, the outlet, to the bladder, is hardly 2.5 centimeters or 1 inch. So, and we cannot stop women gossiping with their fellow colleagues, sitting in a bench, sitting in a place where I don't know whether it is infected or divided, but they feel proud to sit anywhere wherever they get 2 to 3 more females to gossip with. And that leads to the most commonest incidence of getting the lower tract in urinary tract infection. Bladder and urethra, very easily it gets corrupted. And women are always, that is why we say the women are always at a greater risk than UTI. Mostly, see all these gossiping ladies are in between 20 to 50, and they are the vulnerable group in this group. So incidence wise, if you see UTI is the second most common infection following respiratory tract. 40% of all women will suffer at least once UTI in lifetime or some point of lifetime. 1 in 5 women between 20 to 65 will suffer at least one attack per breath. This is the thing which you need to understand. 1 in every 5 women from the age group of 20 to 65 will suffer one attack per day. But how much common and how much necessary it requires for us to treat. Again, approximately 30% of all pregnant women will suffer from UTI. Is my slide moving? Hello?
Yes, sir. Yes,
Okay.
sir, it is moving.
Okay. But in the delicate, I'm not seeing that it is moving because I'm on both the things. Yeah, now it's moving. So risk factors for UTI. Basically, we need to understand 4 general things. One is iatrogenic or drug that can lead to UTIs, like indwelling catheters, antibiotic use, overuse of antibiotic or minimum use of antibiotic, or many a times we see patient doesn't take full dose of antibiotic. These are the things which leads to our iatrogenic causes or drug-induced UTI, as well as spermicides. Like most of the 20 to 60, they are already in the reproductive age group and they have got a husband and using of spermicides or using of condoms. But now, mostly most of the condoms, they'll contain spermicides. Second, behavioral changes like voiding dysfunction, frequency or recent sexual intercourse. All these things are highly risk factors. Second thing, anatomic or physiological risk factors, like if a patient have a like repeated vaginal delivery, that leads to like breakdown or like the whole system, when it gets weakened, they lead to vesicovaginal reflux. Or female, if they are having like if their perineum or the genital tract is little smaller, because most of the female generally we feel that genital tract is have a big and very roomy vagina. Female, those who are having a shallow shallow, if they will have, if the moment they have a rough sex and all these things, chances of their getting aberrations and all these things are high. As well as in pregnancy, the chances will be high. Familiar general causes may be like genetic causes or geriatric causes, we can call it as. Familiar tendencies that susceptible uroepithelial cells, maybe there are mucous properties, they also might lead to all these vaginal changes. Now, pathophysiology, the most important thing we need to understand, what is UTI basically all about? UTI is nothing, but it is a vulval or a vaginal system which is corrupted by a bacteria, and it leads to initially vaginitis, then it climbs up. Uppermost layer is the urethra. From there, it enters into leading to cystitis. After cystitis, it will lead to pyelonephritis. These are the thing. And now we need to understand what are the commonest bacteria, viruses, they are more. See, first thing we need to understand, 90% of vagina has got a very nice and a robust vulval colonization, vulva and vaginal colonization. So, moment the patient is weak, see, basically we need to understand one thing. If patient is systemically or immunologically weak, chances of them getting bacterial vaginosis is very high. And once bacterial vaginosis happens, chances of getting cystitis is little higher. And the moment patient end up in cystitis and patient doesn't take care, or the doctor, visiting doctor or whoever it is, doesn't take care, the ascending infection sets in and it reaches kidney, and at what we call it as a nephropyelitis. So basically, we see Escherichia coli, the most commonest and the most irritative organism which is held responsible always is 75% to 95 is Escherichia coli, E. coli, what we generally call E. coli and B. coli. Those are all mother and brother system. Second comes is Klebsiella, which is around 30 to 60% of cases we find it. Proteus mirabilis, Pseudomonas aeruginosus, these are all 5 to 10% of patients. They are always mixed with E. coli. E. coli is always one of the such system which is being responsible for it. Second, gram-positive bacteria which are less often found is Staphylococcus, Saprophyticus, Enterococcus faecalis, because this Enterococcus faecalis generally it climbs from the anal canal or defecation. The moment if you do proper ablution, this doesn't set in. But if you don't know how to clean it, but generally if you are using tissue paper and all these things, chances of Enterococcus faecalis is little higher, because you should know. See, when you are copying Britishers, you should know how they clean their like after motion or after all these things. Streptococcus egg-litis, this is another very recent thing which has been isolated, but it's pretty rare. In hospital, what happens? Again, E. coli is little less, but here what happens? Enterobacteria, Pseudomonas serrata, they are about 40%. They are around 3 times higher than in general population. So just to understand the anatomy, what we need to understand, see, lowermost is the ureter. From there, infection climbs up. It colonizes in urethra, then it climbs into bladder. From bladder, what happens? There will be a systemic involvement with uroepithelial penetration. From this penetration, the infection go on ascending through the ureters, and ultimately it will reach kidney. This ascending portion, if the ureter flow, urine flow and all, if you are taking less amount of water, if you are drinking less amount of water, there will be chances of all these things. On top of it, if due to your less water and small calculus formation, they will keep on eroding the urethral urothelium, and your chances of having ascending infection is very high. Then after ascending, it will lead to pyelonephritis, and at last acute kidney injury will be there. And this is the ultimate thing where you don't have any other thing, just to visit a doctor like nephrologist and keep on spending your hard-earned money. So this is where we need to understand that where and how we should take care. Most of the thing, always we should know that if we are having a urethral or erythritis or vulval vaginitis or there will be always burning with urination, pain during urination, as well as white discharge will be there. The moment all these things happen, we should be very careful. Again, when it ascends into the bladder, the symptoms will change from burning thing. It will become pelvic pressure pains. It will have a lower abdominal discomfort, frequent and painful urination, as well as blood in urination may also be seen. At last, when the from bladder it has ascended into the kidney, more and the most commonest feature the patient comes with, sir, I have got a back pain, I've got a pain in my flanks are paining, I've got spikes of fever, shaking and chill fevers will be there, nausea may be there, vomiting may be there. All will have a very diverse course of symptoms, and which as a doctor, because being a gynecologist, it's very easy for us to think that okay, chalo, we are patient is pyelonephritis. But for any other doctors, no, vomiting, nausea, they'll start thinking in the line of malaria, typhoid, and all these things, and which might not respond. That and an antibiotic what we are using might not respond properly. So again, we need to understand what is uncomplicated UTI. Generally, 30 to 40% of all UTI won't show much of structural or functional abnormality in urinary tract, nor the patient will be pregnant, nor they will have significant comorbidity. So complicated UTI will always be present with either patient is a child or a pregnancy or supportive behave complications will be there. Corroborative symptoms will be there, like pregnancy, we are less intake of water. Some comorbidity will be there, like kidney disease, immunocompromised patient, diabetes, poor or many a times patient comes with recent instrumentation or surgery of urinary tract. Now the complication, basically this is a complication we need to understand. The recurrent infection, especially in women who experiences 2 or more UTI in 6 months or 4 months, these are the complications generally we see. Permanent kidney damage rarely we see because it goes to a nephrologist. Increased risk in pregnant patient is we always see delivering a low birth weight baby or a premature child. So this is where we need to understand, whenever a UTI complication is there in pregnancy, chances of having a low birth weight baby is very high, or a premature infant, because chances of having premature rupture of your membrane will be very high. Sepsis, a potential life-threatening disease, it can't be ruled out as far as urinary tract concerned. See, how do we diagnose? Basically, we see diagnosis is very important. Diagnosis first is we need to undermine whether it is urinary tract infection, whether it is upper or lower, or whether it is simple or complicated. These are the things we need to understand. And in investigations are very simple and very thing. First thing, urine collection has to be a clean catch, midstream urine specimen, and the specimen must be obtained if a patient is like bed, if is admitted patient, or it has to be catheterized and taken. If a sexually transmitted disease is suspected, urethral swab also should be taken for STD testing as well as voiding testing. Deep testing is accepted, or along with it, nitrate positivity is also there, or leukocyte esterase test is also a specific test where we see a presence of more than 10 WBC per microliter. Microscopy examination. These are the things we generally, I don't know, most of the gynecologists, they'll have their own laboratory within their own premises. See, I prefer to see it within my own chamber. In my chamber, I've kept one high density microscope. There I see even colposcopy I do, and all these things I do, so that it eases me. I can see all these microscopy. I ask my medical laboratory technician to show me the all cultured here. I see personally. I'll see the like after doing a I'll after making the urine in the compact case system, I see it in the microscope, so that I can see most of the things which is there. And personally, one thing I want to say, doctors, as far as gynecologists are concerned, we should be more concerned about patient benefit than just seeing a report, because these things, the more doctors they see directly, chances of catching the things are very high, because all these thing, most of the like laboratory has been manned by technicians, and they are not responsible for most of the things. So culture recommendation is always done whenever the colony count and all those things are high, or the number of WBC count is high, especially when the patient is pregnant or postmenopausal, pre-pubertal children's, pregnant patient with urinary tract abnormalities or recent instrumentations, patient with immunosuppressant drugs or specific comorbidities like diabetes or renal transplant, or some transplant is there, or patient whose symptoms are like pyelonephritis or sepsis, or patient with recurring UTI. These are the things we need to see. And urinary tract imaging choices includes ultrasonography. These are all available everywhere. CT and intravenous urography or pyelography can be done. Children with UTI are often require imaging, and most of the adults don't require assessment as such. Their history, all those things are enough, and one or two small microscopic or centrifuge sample is enough for us to see microscopically what has happened. Centrifuge sample is the best sample, which gives us all about infective courses. Because generally, if you see a randomized microscopic examination, we fail to catch up many of these pyelonephritis. And nephrolithiasis, the moment we see calcium oxalates or all those crystals are there, we know that this patient is ending up in nephrolithiasis. And most important, there can be painless hematuria or there can be painful hematuria along with renal insufficiency. These are the things we need to be very cautious about, as well as if the fever is persistently more than 72 hours or 3 days. So, like going for the differential diagnosis, we need to understand that acute urethral syndrome. This is a syndrome which occurs in a patient, and is a syndrome involving dysuria, frequency of urine, pyuria. All these things, they resemble like cystitis. However, when acute urethral syndrome happens, routine culture will tell us that all are negative. Urethritis, this is a possible cause of positive organisms like chlamydia, trachomatis, and uroplasma urinaticum. These are the things which is not detected in routine urine culture, but we have to be cautious, and we have to see non-infection causes are anatomic anomalies, physiological anomalies like pelvic floor dysfunction, like repeated recurrent deliveries and all those things. And if the pregnancy delivery is not conducted by trained personality like doctors and nurses, we will have all these pelvic floor dysfunctions. Hormonal imbalance like atrophy uterus. When post-menopause ladies, generally we come across, whenever a patient comes, generally then we'll see your stress incontinence, urge incontinence. All those things are there in post-menopausal ladies, as well as localized trauma, GI symptoms, and inflammation is also there. Management is very simple. If urethritis, if it is in the outer and the most outer portion is there, course with azithromycin or doxy is enough. And nowadays we can use cefotaxime also. Previously, doxy was drug of choice. And many a times I have seen even thimetoprim sulfamethoxazole is also very good. In first, don't try or hire the injectables in small things. It is just like for an ant, we are taking out our revolver. Cystitis, again, first line of uncomplicated cystitis requires only nitrofurantoin, but it requires little long treatment with nitrofurantoin also, because these are all very low group. As well as trimethoprim sulfamethoxazole can also be tried. 160 trimethoprim and 800 sulfamethoxazole. These are the all age-old medicine. We used to call it Bactrim DS. Bactrim DS now, during our childhood also, we used to see every patient used to carry one Bactrim DS. Why now? This problem is there, then that problem is there. Now, coming up to the acute pyelonephritis, the management of the two, where you require a doctor or a gynecologist or a nephrologist or urologist to treat. Antibiotic is required. Outpatient requirement to oral antibiotic is possible if at all patient satisfies few conditions. Because see, most of the time we need to understand whether patient is compliant or patient is non-compliant. If patient is non-compliant, please don't allow him to go admitted for 5 days at least till the things are under control. Expected patient can be there, or patient who lives near and you can leave it. But for immunocompetent patient or patient there who are having vague complaints but septicemia is high, we need to admit and give ciprofloxacin BD for 7 days. Or second option is again your Bactrim DS 160-800 BD for 14 days. Alternative method is when we start supplementing with our pharmaceutical mixed with nutraceutical component like cranberry concentrates with increase in increase of fluids, ural ursocholic acid. It is a urine alkalizer also. So antibiotic, I don't know to go in all these detail because most of the thing we have been practicing now. Trimethoprim and all, most of the places it's not available also. Amoxicillin we are trying, nitrofurantoin we are giving, cephalexin group we are using. In non-pregnant women also, we need to understand one thing very clearly, that what is the age of the patient, how many symptoms she had, or what is the level of symptoms, what is the level of her compliance, and what is the level. All these things leads us to go for alternative diagnoses, as well as considering pelvic dysfunction, as well as pelvic examination is important. The moment we see dysfunction and all these things, we need to address vaginal itch also, as well as discharge also. Dipstick is a very good guide treatment in making decisions, as well as healthy women. beyond 65, mild or major UTI, we need to treat in a daycare also. Second thing is what antibiotic, how many when we require to treat a lower urinary tract infection. Lower urinary tract infection does not require much of problem because these patients lower urinary tract are basically either very young age or very late age. And particular care should be taken while prescribing nitrofurantoid because in elderly patient which may increase toxicity, as well as urine culture is always to be the guide for antibiotic usage as well as antibiotic care and antibiotic follow-up also. Second thing, now symptomatic bacteria has to be graduated, and we need, as a doctor, pregnant patient, symptomatic bacteria is very high, and we need to understand and see which group of medicine, because in pregnancy, all we know most of the antibiotics are in either in grade 3 or grade 4 toxicity, so we don't use it. And we should always confirm the presence of bacteria in urine. Second thing, dipstick doesn't give much of this thing. It is always better to have a microscopic examination after centrifuge. And treatment of asymptomatic bacteria in pregnancy with antibiotic is always required. Now, antibiotic treatment for pregnant women, we should know that if it is symptomatic, we need to get a culture done, or randomly we can start off with amoxicillin, cephalexin, or augmentin group. And if the patient is symptomatic or bacteria is present, then after following urine culture, we do it then. So many now the heat treatment or patient or pharmaceutical companies, they are coming up with so many nutraceutical products like cranberry extract, then ursolic acid, product containing ursolic acid. So many things are there, and ultimately when we get to our system and when we have tried with so many, because it is always better, because nutraceutical things are easier to get, they are less toxic, and they are more compliant to patient in a general as well as in a far remote areas. And it is cost effective also, ursolic acid as well as cranberry. The advantage of ursolic acid is it's a very powerful anti-inflammatory and analgesics. It inhibits the pro-inflammatory project, like inflammatory cytokines like human nuclear factors and prostaglandin E2, which are the cause for all the pains. Anti-inflammatory effects are comparable with all NSAIDs also, and it is a very powerful antioxidant, and it prevents tissue damage as well as inflammation due to respiratory oxidative species. So again, if you see many like papers had been passed by Salvia ophalis, as well as when we talk about ursolic acid, it is extract from the Salvia officialis. And main thing, again, in most of the places, many you open any medical or urological, and you get so many papers, and all are showing very high effects and beneficial effects as well as cost effective treatments with cranberry extract as well as ursolic acid extract. I don't want to go in all this, because main thing we need to understand, these are all pharmaceutical companies. It is under treatment now, as well as it is under immense researches. We at John Hopkins Baltimore, as well as at Indian in Singapore, where I'm heading now in Southeast Asia, we are doing a lot of exams just to see, to make cost-effective treatment protocol also, and most effective treatment also. Potassium magnesium citrate is also a pharmaceutical company which is being used, and it produces very high concentration of bicarbonate in urine, and it neutralizes the acidic urine and infective urinary tract. And mostly burning micturition is released by this magnesium citrate. So D-mannose is another product, pharmaceutical product, which is being used as to bacterially is detaches the femoral end of all these like E. coli and all these like infective agents. And basically what happens, they get attached to the urothelium. But use of D-mannose uses them to get attached from that site due to presence of the uteroplakin. These are three, few glycoprotein receptors are there. They used to come, competitive adhesions are there. Adhesin is a substance which attaches to the system so that all these E. coli, fimbrias and fimbriated things, they doesn't stick to the system. And for that, we need to understand female adhesin is a very nice way. It prevents bacteria from getting attached to the urothelial glycoprotein receptors. So you can see here a very nice photo made by the Escherichia coli, E. coli. They are having the P. fimbriae. They get attached to the urothelium, and it is this D mannose which disembark them from the attachment to the urothelium. Again, for prevention, one most common thing is plenty of liquids has to be drank, so that along with cranberry extract or your this D mannose, the moment the E. coli is destabilized or it is detached, we need to flush it out, and for that plenty of water is always required. And we need to understand always that if anybody has got a clear urine and has got a clear habit of nature's call like motion and as well as sweating, if a patient has all these things in a very clear way with a good way, we don't get patient having all these problems. Prevention is the first thing what we need to understand. Post-coital prophylaxis has to be understood, and patient has to be very, very, very meticulously be safe during the, because post-coital time is the most vulnerable lady is for. That is why we say after post-coital you should always wash your genitalia and make yourself clean to get back to your bed. Because once once from the exterior, if you are during intercourse and all this, if the vaginal mucosa get traumatized, chances of that retaining your bacteria and vaginal and vulval flora is very high. Again, in postmenopausal, what happens? Because of this asthenic or thin or atrophic vagina or vulval mucosa, as well as everything loosens, so that leads to your prolapse of cystocele or enterocoele or rectocele as well as urethrocoele. All these cystocele and urethrocoele are all responsible for this thing. When antibiotic prophylaxis has to be given to all these females whenever we are coming, along with a tropical estrogen cream. We generally nowadays it is available left and right. We ask them to apply with estrogen, as well as now even phytogens are also available for all these postmenopausal women. We supply this nutraceutical estrogen binding proteins also. So to summarize it, urinary tract infection, it is an infection in any part of urinary system that we need to understand. And it is the most dependable and vulnerable part of any female. Females are more prone. 40% of all females will suffer at least once. Though incidence of bacteria is in pregnancy is slightly higher than non-pregnant, chances of progression to your pyelonephritis is significantly higher, to the range of 40%. Higher chance of pregnancy complication is always there, like low birth weight baby as well as PROM leading to premature baby. First line of therapy always includes antibiotic along with D mannose as well as your arsolic acid. Nutraceutical provides relief from pain, burning sensation, and hot flushes. All these things are relieved by your arsolic acid as well as D mannose. Thank you very much.
Thank you very much, sir, for this nice deliberation. Just give me 1 minute time, sir, to check any question in our dashboard.
Sure.
Sir, one question is how to treat this asymptomatic bacteriuria in case of pregnancy, sir?
In pregnancy, what happens? If basically it is very difficult to catch one asymptomatic bacteria. If it is caught, first thing, generally we need to give some safe antibiotics like amoxicillin or your raquitostrol. Those are the few that we comes along with D mannose as well as D mannose and arsolic acid. They are all safe in pregnancy and we can use very left hand, but it should be used under gauge along with the antibiotic. See, nitrofurantoin is also safe in second or third trimester pregnancy, as well as our thing what we are using right now. And one thing we need to understand in all asymptomatic things, that water is the treatment. Water along with lemon is the treatment. Lemon is the motorcycle which carries the antibiotic or the water to the area where it requires to be covered. Third thing, water, lemon, jaggery or honey. These are all immunostimulant, as well as jaljeera powder. These are the best combination along with your D-manos and all. They will lead you to getting it flushed fast. And 4 liters of water is a must.
Thank you very much, sir. And sir, another question is, sir, another question is there any difference in the treatment protocol during this pregnancy period in each trimester? Is there any change in the treatment protocol?
Yes, one thing, very nice question. See, this is the thing we need to understand. First trimester, that too, first trimester means first 6 to 7 weeks. This is the time where organogenesis sets in. This is the time we need to be very, very, very cautious about all these things. And we need to select medicines as per complication or as per which grade the drug falls in. Got it? Generally, we try to avoid. We just ask them to take medicine like water and D-manos and all these things, so that all nutritional elements which don't have much effect on the baby or which doesn't crosses the placental barrier. Got it now? Second,
Yes.
second, when it is after 10 weeks, we get a chance, we can start doing our cultures and all these things and start treating. And we give mostly the medicines which are safer in pregnancy. Third trimester, because already the baby is well matured and all these things, and if a patient is having recurrent infection with pregnancy and patient is coming with after 32 weeks, we can do anything. Either we can transform the treatment protocol, we can take out the baby and treat the mother in a full scheme, because we need to treat, because if the urinary tract is not taken care properly, see, the baby after 32 or 36 weeks, baby is safe. We can give the baby in incubator and treat. If we don't treat the mother, what happens? The mother loses a very important vital organ, that is kidney. So we need to keep always that in head, that we are treating the most vulnerable portion of that mother. So we need to be very cautious.
Thank you very much, sir. And sir, one thing, this cranberry extract or D-manos, how do you recommend in case of your practical practice in terms of pregnant or in terms of non-pregnant women?
So, as well as pregnancy and both I give. It's not because it is not my choice, because it has been proven. But for last 7 years, I've been using. After reaching India, we did a lot of studies. Still now, I'm in around 7 studies. Even in international market also, we are using this. And we have started off with around 300 centers. Meta-analysis is going on. Our data will be saved in Cochrane database. And we are enlightening and highlighting, because these nutraceutical products, like your ursolic acid as well as D-manos, they have got a very supportive or like additive portion to the antibiotic what we use.
Thank you very much, sir. So, sir, I could not find any other questions. So, thank you very much once again for your valuable time.
Last thing,
Yes,
before closing, see, ursolic acid, they have got a very less tissue toxicity, and they are very sensitive to urothelium.
sure,
And
sir.
like we are doing little finer studies right now, and after I think another year or so, we may come out with a beautiful study, because we are just counseling, or we are just treating around 32 lakh patients pan world with an urinary tract infection. Is such a common infection. We generally see it in any gynae OPD wherever we go. Out of 50 patients, 25 will be only of urinary tract infection. That is why we are so cautious and we are so concerned about it. And whatever we do, we know that we should do it in a very supplement way, so that patient gets the benefit of our treatment.
Thank you, sir. And just last one thing, sir. Sir, from your side, any advice that a doctor should give their patients to reduce the chances of this UTI infection in pregnancy? What is your suggestion, sir?
See, sir, like here in Dhanbad, see, when I'm in abroad or here, generally I don't see generally or general patients. My wife takes care. But in India or in Dhanbad, we need to see all patients. So
Yes.
generally, whenever I see a patient, I first day I give them 30 odd minutes to make them understand these are the organs which will be compromised. First thing is urinary tract infection, because our body or system, they get more than 1.5 liters of water as an extra in pregnancy, and that has to be manipulated properly. I give them in writing and tell them take 4 liters of water. And people should not laugh at my, because but expecting being a doctor from John Hopkins Baltimore, if we advise them to take ajwain water, that is the best
Yes.
water anybody can take. Ajwain 4 liters per day they have to take, and that too they have to start making it in the previous night. Previous night they have to take a bottle or a pan per head. 5 liters of blood, water has to be taken, and 3 to 4 teaspoons of ajwain has to be taken. That has to be soaked, pre-soaked, and early morning it has to be boiled and kept in 4 jars, and they need to finish it up. 4 liters of water they have to finish it up. Second thing, 2 lemons they have to drink along with the ajwain water, as well as uh, uh, jaljeera powder and your jaggery or honey. These are the things. And second thing, don't sit here and there wherever you want. Third most important is, like, you need to understand that you are going to become, or you are going to get the most coveted post of being a mother. So you need to understand that you are going to become the most coveted like word. So you need to take care that you are taking care of a baby, and the baby is still unborn and still within yourself. So it is you as a mother. You need to understand that you are dedicative all these things like nutrition, food, water, even your lemon, 4 liters of water. That has to be must. And whenever you have got any burning issues and all these things, please rush to a doctor, because doctor is always there to take care of you. That's the thing which I tell them in Hindi, English, whichever vernacular language they are, because I speak 17 Indian languages. For me to speak Kannada or Telugu is very easy. And I try to make the patient understand in their own vernacular language always, not in English or Bengali, which I am more used to, because I am a Bengali doctor.
Thank you very much, sir, for this nice discussion. So thank you very much, sir, once again for your valuable time in our platform Shift Connect. And I guess Biplabda is going to say something. So Biplabda.
Thank you, sir. Nice presentation, and last 5 minutes was excellent discussion, sir. Thank you, sir. Thank you, and thank you all delegates.
And
Thank
it's
you.
our pleasure to have you on board all the time, sir. After your busy schedule, also that we also know.
Feel very happy. No, it's more than that. See, we feel happy, like, because if the listeners are more, we can share more.
Yes.
That is why I try to always, if a 1 hour topic is there, I try to finish within 45 minutes, so that 15 minutes I should give for discussions. Because my main thing which people they love in all these medical forum discussions is my seminars. They love to discuss with me because I talk to them in the core, and this initial concept thing has to be conceptualized, and then only you can get a proper like medication and medical advices to our dear patients.
Yes, thank you very much, sir, for this nice deliberation. Thank you very much once again, sir, for your valuable time.
Thank you, sir.
Next time we will be look forward for some valuable session with you, sir.
I gave that nutritional one for your one nutritional thing is there, estrogenic product.
Yeah, we have Estrogy with us, sir.
Estrogy.
Estrogy 100 with us, sir.
Therefore, yesterday only I had a we are off the line or we are still in the line?
Aditi, we can close this session now. You can off this
Okay,
YouTube
sir,
live.
I'll end.
Not end, it's YouTube live, you just close.